goes back to Vegas, so we took him to Vegas.
I was going to say, how many books?
But I just kept saying, like, this is not really a, not really America.
All right, let's get started. Len's still in Cuba. I think he defected. But let's get started. I think there'll be a smaller audience in-house today because of all the accidents in the area. Thao Tran is talking to us today about the small topic of hypereosinophilia. So she has a lot of slides, so we'll get going.
Thank you, Drew. All right, we'll just get started. Today I'm just going to try to get through an overview of hypereosinophilia. I'm going to present this as if hypereosinophilia was an incidental finding in our clinic and it was a referral. But just to get started, I have no conflict of interest. But first, to begin the talk, we're just going to review the biology of eosinophils really quickly, nothing in depth whatsoever. Then we're going to go through the current classification definition of hypereosinophilia itself, go through the very narrow differential diagnosis of hypereosinophilia, and then a general recommended approach to hypereosinophilia. There's been multiple recommendations through the decades, but there are several consensus articles out there in the past few years. So eosinophils, just a quick review, are granulocytes that develop in the bone marrow, pluripotent progenitor cells, and they're mainly well-defined cells upon exiting bone marrow. But they migrate the peripheral blood, and in their phenotypically mature state, but they don't persist in the blood that long. Your usual T half-life is only 18 hours, and usually in normal, healthy condition, they migrate to the thymus or the GI tract, not the esophagus, and reside there in homeostasis. But once inflammatory stimuli are sent from the tissue, they usually migrate and persist in the tissue where their cytokine action occurs. And so when they get recruited to the tissue, usually it's due to some inflammatory stimuli, and that's where tissue inflammation, tissue fibrosis, due to eosinophil release of their cytokines occur. And eosinophils have an innumerable amount of cell-specific mediators out there, as well as non-specific mediators of inflammation. And if you look at any of the Nature Review of Biology, you see a little eosinophils and a whole bunch of acronyms. So I'm not going to go through all that. But the major cell-specific mediators of eosinophils are eosinophil cationic proteins, major basic proteins, eosinophil peroxidase, and eosinophil-derived neurotoxins. And these are often used also in analysis as tissue markers of eosinophil presence. And so really quickly, factors promoting eosinophilia, the interleukin that is renowned for it is interleukin-5, IL-3, and GM-CSF. Is also a primary factor, and they're important for differentiation, survival, adhesion, migration, and tissue activations of eosinophils. And IL-5, IL-3, and GM-CSF is usually released by activated T cells, mast cells, stromal cells, eosinophil cells, as well as numerous other cells. And another chemokine that's important is the eotaxin. They're important in the activation and chemotaxis of eosinophils into a tissue. And there are also important negative regulators of eosinophil. Cyclic 8 induces apoptosis of mature eosinophils. TGF-beta induces apoptosis also. Interferon alpha, also used in therapy, inhibits growth and differentiation. Interferon gamma also inhibit growth and migration. And as we already know, glucocorticoids also inhibit expression of eosinophils and migration of eosinophils to the tissue. So eosinophilia, blood eosinophils are usually less than 500 cells per microliter in peripheral blood. And that's normal. And mild hypereosinophilia is seen through multiple diagnoses. And mild is considered between 5 to 1,500. And most atopic diseases that we know of, allergic rhinitis, asthma, mild atopic dermatitis, their range is between, within this range, around 1,000 or less. And then the definition of hypereosinophilia is really defined by the, what is also called marked hypereosinophilia, which is greater than 1,500 per microliter. And to define it, you have to have 2 blood hypereosinophilia of an interval of greater than 1 month. So it's really hypereosinophilia with persistence that's important. And then there also can be evidence of tissue hypereosinophilia. Oh, sorry, this is a Mac issue. So tissue hypereosinophilia is poorly characterized. We know that most tissue do not have eosinophils in it, except for the thymus, spleen, lymph node, uterus, and GI tract from the stomach to the large intestine. We don't see it in the esophagus. That's why eosinophilic esophagitis is defined as usually at least 1 out of 4 biopsies showing about 15 eosinophil per high-powered field. But the truth is, the problem with tissue eosinophilia definition is that it's poorly defined. Not a lot of people have gone through the studies of, deciding and characterizing what's elevated eosinophil per tissue. So, with bone marrow tissue eosinophilia, if you see the percent of eosinophils per bone marrow section exceeding 20%, is considered elevated eosinophils in the bone marrow. Normal is between 1 and 6%. And then, in the pathologist's opinion, is there's extensive tissue infiltration, eosinophilia. That's tissue eosinophilia. And then you can also see marked deposition of eosinophilic proteins without actually seeing the eosinophilia presence itself. And that can still fit into the definition of tissue hypereosinophilia. And then hypereosinophilic syndrome is really the definition of HE, hypereosinophilia, with some evidence of organ damage related to the eosinophilic elevation itself. And this is usually seen in the heart, lung, skin, can be seen in the spleen, GI tract, and CNS also. So, you see hypereosinophilia, it's greater than 1,500 per microliter. What are the classification of hypereosinophilia? Because it's a huge differential diagnosis. So one of the main things that you need to rule out for hypereosinophilic presentation is that is there a secondary or reactive cause for the hypereosinophilia? And that's categorized into 2 subsets. There's the non-neoplastic causes, and then there are neoplastic condition. And really secondary is due to whatever pathogenesis there is. There's an increased release of eosinophilic poietic cytokines, inducing elevation of eosinophilia. And then there are these defined syndromes associated with hypereosinophilia, and we'll go through the differential diagnosis for that. And the defined syndrome is interesting because you'll see hypereosinophilia. There's some association of the pathogenesis associated with the elevated eosinophil, but the actual activity of the eosinophil itself may not be related to the disease. And then there's the organ-restricted inflammatory condition accompanied with hypereosinophilia. That's your eosinophilic esophagitis, your chronic eosinophilic pneumonia. So they have hypereosinophilia, it's tissue involved, but they really don't fit the hypereosinophilic syndrome category. So, and then finally, we move over to another group is the primary or clononeoplastic hypereosinophilia. So these are diseases that are involving in clonal production of the eosinophil itself, and these are the more severe diseases. And then there's the hereditary idiopathic hypereosinophilia. So you fall into those categories when you rule out everything else. So reactive hypereosinophilia, non-neoplastic or paraneoplastic condition leading to non-clonal expansions of eosinophils. We all know the respiratory associated disease, asthma, allergic rhinitis, but they're rarely associated with the marked hypereosinophilia. Chronic rhinosinusitis with nasal polyposis is also associated with this. I'm just going to give a quick review of allergic bronchopulmonary aspergillosis, or mycosis. This is the criteria for ABPA. This is one of the more common respiratory hypereosinophilic diseases that we'll see aside from our very common asthmatic disease. But the minimal criteria for ABPA is at least asthma, chest X-ray infiltrate, positive prick test A fumigatus, and then elevated serum IgE, usually greater than 1,000, and elevation can be quite high for IgE, can be in the tens of thousands. And then evidence of precipitating IgG antibodies to A fumigatus. So, and then the minor criteria are also blood eosinophilia, and they can range as high as 5,000, or even higher. So, and then of course, if on imaging study you see central bronchiectasis, you definitely consider ABPA in the differential diagnosis. The criteria for patients with cystic fibrosis and ABPA are very similar, but nuanced because of the overlap of symptoms in cystic fibrosis already. So one of the nuanced change with ABPA diagnosis in cystic fibrosis children is that it can present as an acute or subacute clinical deterioration, not attributable to other etiology. But otherwise, very similar diagnostic paradigm. So ABPA is as a reminder, a hypersensitivity lung disease seen in 1 or 2% of asthmatic, or up to 7 to 9% of cystic fibrosis patient. In asthmatic, the blood eosinophilia can be greater than 1,000 per microliter. 3,000 is very common. Curiously, blood hypereosinophilia is not often seen actually in patients with cystic fibrosis. Treatment is corticosteroid and itraconazole. And then the small area, this is a talk in itself, infection and hypereosinophilia. All helminthic infection can lead to hypereosinophilia. HIV infection is associated with hypereosinophilia in usually less than a quarter of the patient population. And curiously, protozoan infection, like Giardia and Enterolytica, are not usually associated with hypereosinophilia, except for sarcocystis. So we'll go through that, and then scabies. Scabies can have presentation of hypereosinophilia, but that's also a very rare, small percentage. So, Helminth infections all cause hypereosinophilia, and the eosinophilia is often seen at the early stages in the infection because eosinophilia is usually seen when the parasites are migrating through the tissue from muscular tissue or GI tissue through the pulmonary walls, through the CNS. So you definitely have to think about hypereosinophilia and helminthic infection from travelers or patients coming from the tropics. And it's curious. They say if you see hypereosinophilia and they're coming from the tropics, that the eosinophilia itself is a marker of parasitic infection with only sensitivity of 30 to 70%. The positive predictive value of it is only 15 to 55, but the absence of eosinophilia has a specificity of 91% and a negative predictive value of 75 to 95%. So this is just a quick guide to what to consider in patients coming with potential helminthic infection based on their history. But the approach of helminthic infection, hypereosinophilia, is difficult. You really have to figure out where they travel to or where they come from, what are the endemic helminths in that area, And then, based on their clinical signs and symptoms, you narrow down in this huge differential. So, majority of the time, very rarely will they have these specific pathophysiological signs that makes you consider specific infections. Majority of the time, they have no focal findings, and you'll end up doing an ovarian parasite. Remember, it's the accumulated ovarian parasite that is of value. So at least 3 different stool culture over at least 1 per week period. And you could do serologies to a number of parasites also. And talking to Dr. Cleon, Amy Cleon, serology, sadly, it's not very sensitive or specific in a lot of our laboratories. She recommended considering sending the serology to the CDC or considering doing serology at the ARUP lab. They tend to have better sensitivity and specificity with their serology for parasites. But the most important helminthic infection to consider is strongyloides. Strongyloides is actually endemic throughout the tropic and subtropic, but also the southeast region of the U.S., as well as Appalachia. So definitely consider that for patients presenting there, especially in rural communities. And the problem with strongyloides and hypereosinophilia is if you suspect this, you definitely should think about empiric treatment with ivermectin, which is a broad-spectrum antiparasitic that's well tolerated and highly responsive for strongyloides infection. Because any treatment for hypereosinophilia that's an immunosuppressive, first-line glucocorticosteroids, hydroxyurea, can lead to a huge infestation and infection of strongyloides into the patient's system, leading to life-threatening complications. So this is called a hyperinfection syndrome of strongyloides in the setting of immunosuppressant. So the problem with patients with strongyloides is they can have this for years and be asymptomatic. They have intermittent urticaria and usually the curl area. And they can also have non-specific GI symptoms of abdominal pain, bloating, diarrhea. And peripheral eosinophil is not an absolute must in these patients. It can range from 0 when they're asymptomatic to as high as 80%. So to diagnose strongyloides, you obtain ovarian parasite. Serology is poor. We've talked about that. Consider ARUP. And it takes about 2 weeks to get serology results back. And empiric treatment with ivermectin is highly tolerated and quite effective. Another infectious, so most viral and bacterial infection often cause eosinopenia rather than eosinophilia. Except for HIV, there's definitely an association of hypereosinophilia with HIV infection. About 10 to 19% of the developed country patients in the developed country have hypereosinophilia, and as high as 25% in developing country. And there's definitely an association with HE and HIV in patients with parasitic co-infection. Also association with drug allergy and malignancy. And hypereosinophilia may be a relative eosinophilia, especially in patients when their CD4 count is low at the nadir. Sarcocystis. Only 2 protozoas associated with eosinophilia, sarcocystis, and isosporia. But isosporia, according to Amy Cleon, is nearly eradicated, so it's definitely much lower in the differential diagnosis. Consider from patients in tropical, subtropical region. So sarcocystic infection can be dual source. One source is water and food contaminated with feces. And this leads to muscular infection. They could be asymptomatic for weeks and years. They could have presentation of musculoskeletal pain, fever, cardiomyopathy, bronchospasm, subcutaneous swelling. And sarcocystis in this form is associated with hypereosinophilia, and diagnosis is actually biopsy of the muscle. Now, sarcocystitis can also be due to ingestion of raw, undercooked beef and pork, and this actually leads to acute symptoms that occurs within 3 to 6 hours, lasts 36 hours, with severe nausea, vomiting, loss of appetite, and tachycardia. And then there is the association of hypereosinophilia with drug allergy, and one of the main area of drug allergies that should be addressed is the DRESS syndrome, the drug reaction with rash and eosinophilia and systemic symptoms. And DRESS is rare, but definitely involved in anti-epileptic therapy. That's something we all should consider. But presentation of DRESS is skin rash, usually erythrodermic, liver involvement, hypereosinophilia, lymphadenopathy, fever. Incidence can be high as 1 in 1,000 to 1 in 10,000 drug exposure, and it is a potentially life-threatening syndrome. The mortality rate can be as high as 10%, and the drug that's often associated with a high mortality rate is actually allopurinol, most of the drugs. So. And the interesting thing about DRESS is there's quite a delayed onset for most of the drugs, usually 2 to 6 weeks after the initiation of drug therapy before DRESS symptoms occur. And so there's several mechanisms depending on the drug that's implicated in DRESS syndrome, but there's evidence of detoxification defects leading to reactive metabolites in a lot of the anticonvulsant, as well as association with the sulfonamide-related DRESS syndrome. Slow acetylation is associated with a few. And then, very interestingly, especially with the HIV drugs, there is definitely association with reactivation of human herpes virus. And there's one prospective study that showed 40 DRESS patient, not HIV patient, but 40 DRESS patient, 76 of them had reactivation of human herpes virus. So that's something to consider in screening when you're looking at DRESS patients. So there's a multitude of drugs associated with DRESS.
Now, can I ask you a question about the herpes reactivation? Is that big rash that you see on the skin actually a herpes infection, or is this more of a laboratory?
It's more of a laboratory correlation to it. So,
yeah. Okay.
Yeah, and it's used as a marker, in your consideration of DRESS syndrome. DRESS. The carbamazepine, lamotrigines, phenobarbital account for 1/3 of DRESS drug association. And just to be aware that the cross-reactivity for these aromatic anticonvulsants are well documented. So once you have DRESS to one of them, you should avoid all of them. And then, as we mentioned previously, allopurinol has the highest mortality rate in DRESS-associated drugs. So, and this is just a pie of DRESS syndrome in one study, but it's reflective of most studies out there. So, phenytoin, allopurinol, nifedipine, dapsone, sulfasalazine, those are the drugs of consideration. And then there is neoplasm associated with reactive hypereosinophilia, not primary eosinophilia. And Hodgkin's disease, as well as some non-Hodgkin's disease, is associated, hypereosinophilia is seen in about 5 to 15% of these patients. And there's evidence that the Reed-Steinberg cell in Hodgkin's disease produces a lot of interleukin-5, inducing the hypereosinophilia. You can see it in T and B cell lymphoma, leukemia, Langerhans cell histiocytosis, numerous amount of solid tumors. And then the more important one, part of the hypereosinophilic evaluation is you also look for these lymphoid neoplasm, and they're called the lymphoid variant hypereosinophilic syndrome. And they're clonal T cell with CD3 minus, CD4 plus variant markers out there. And what's important for about classifying these type of lymphoid neoplasm is they're highly responsive actually to anti-IL-5, so which is the potential treatment in that class. Other rare forms of hypereosinophilia, that's reactive GVHD, chronic inflammatory bowel disease, and indolent systemic mastocytosis. And then there's the defined syndrome. There's a few, and I'm not going to go through most of them, but Gleick's is very rare, Churg Strauss is very rare, but can still be seen. Eosinophilic myalgia is the one associated in the 1980s with L-tryptophan contamination. There's also the toxic oil syndrome that was defined in the 80s to 90s due to contaminated rapeseed oil. And once those were found and taken out of the market, eosinophilic myalgia was markedly declined. Now, I didn't realize it, but I think it was 2005, L-tryptophan was allowed to get back into the market, but since then there was only one case of possible associated eosinophilic myalgia. And then the immunodeficiency, Omen syndrome from RAG1, RAG2 mutation, and hyper IgE syndromes from the STAT and DOC8 mutation can also have hypereosinophilia, but that can be a talk in itself, so I'm not going to go there. Gleick syndrome, this is an interesting but rare disease. This is actually seen with cyclical recurrent angioedema. And I actually had a patient where I thought this was a potential diagnosis, but it wasn't. So, but the patients with Gleick syndrome can present with these episodic angioedema. It can occur once every few weeks, and they're relatively asymptomatic in between. They have hypereosinophilia and they have polyclonal elevation, IgM elevation. And so they have these abnormal CD4 T cell with decreased expression of CD3. And they just produce elevated eosinophilic poietic cytokines. But if you follow them through, they have no other evidence of hypereosinophilic syndrome classified elsewhere. Churg Strauss, we hear about this, we know this, but it's rare, 2.7 cases per million of total population, seen exclusively in asthmatic, men greater than women, and the incidence increases with age up to the 60s to 70s. And it's a necrotizing vasculitis affecting small, medium-sized vessel. There's granulomatous inflammation associated with, and there's definitely eosinophilic infiltration and peripheral eosinophilia. And about half to two-thirds of them are the p-ANCA positive. And they can have three phases: the prodromal phase, which just present like an allergic asthmatic patient. Then there's the eosinophilic phase where they'll have the peripheral hypereosinophilia, and they'll start to present with their end organ damage due to eosinophilic infiltration, usually the lung, the heart, and can include the GI tract. Interestingly, patients who have this stronger presentation often are ANCA negative, while the ANCA positive patient tend to have more of the third phase of presentation, the vasculitic phase, where you have the mononeuritis multiplex, necrotizing glomerulonephritis, and I'm sorry, that should say leukocytoplastic vasculitis, not leukocytoplastic vasculitis. So, and then treatment, corticosteroid is first line. You could do pulses of IV cyclophosphamide for patients with one or more life-threatening manifestation, and methotrexate and azithromycin can be used as a maintenance therapy. Then there's the organ-restricted condition with hypereosinophilia, and you take an organ and you add on eosinophilia, and that's your organ-restricted hypereosinophilia. You can see this in multiple, but we know our eosinophilic esophagitis, eosinophilic gastroenteritis. Yeah. I just want to quickly go over two eosinophilic bronchitis and pneumonia really quickly. I do apologize for this, but eosinophilic bronchitis has unknown etiology, and eosinophilia is seen in greater than 3%. And this is a diagnosis that is interesting because it's found in 13% of patients who presents with chronic cough without any evidence of variable airway obstruction or hyperresponsiveness. And the curiosity to it is they'll have sputum eosinophilia like an asthmatic, but they when the pulmonologists do the biopsy, there's no evidence of mast cell infiltration into the airway smooth muscle in these patients like you would see in an asthmatic. So it's definitely a clinically different presentation. So, and then chronic eosinophilic pneumonia is a very rare interstitial lung disease, about 1 to 2% of the population, and it's due to eosinophilic pulmonary parenchymal infiltration and inflammation. There's a female predominance. The presentation can be indolent over weeks to months, but it's progressive cough, dyspnea, fever, night sweat, anorexia. And the important aspect of this is patients with CEP are highly responsive to corticosteroid treatment. It melts it away in a way, but it does relapse, so you have to use these prolonged courses of corticosteroid. Chest X-ray shows migratory patchy infiltrate, and pathognomonic for it is this photonegative pulmonary edema that's almost diagnostic, but it is only seen in about a quarter of patients with CEP, so you can't rely on that fully. And BAL shows quite an elevated eosinophilia in most of these patients.
So what's photonegative?
What is that?
What is photonegative?
Chronic eosinophilic pneumonia.
No, photonegative pulmonary edema.
In imaging study with chest X-ray in pulmonary edema, you definitely see a pattern of almost general gray scale that lines the bottom,
So you don't see
from
the
top to
typical
bottom,
butterfly
central,
pattern.
yeah. But in chronic eosinophilic pneumonia, I actually had a case as a fellow. I should have brought in the imaging, but it's actually a shadowing of the bronchial lining. So it's a total opposite. It's almost like you reverse the gray image on these patients. Yeah. So organ-restricted condition, other ones that we'll really quickly go through is think about it in bullous pemphigoid, possible patient. Other rare syndrome is Schulman syndrome, Ophogy, Wells syndrome, and then of course dermatitis herpetiformis and a multitude of other dermatologic process out there can have associated hypereosinophilia. So bullous pemphigoid, quick reminder, it's an autoreactive T B cell response to hemidesmosomal antigens, and it causes the destruction of the dermal-epidermal junction, and this forms these blister fluid, and when you test these blister, they have a very elevated level IL-5 and eotaxin, which is probably signaling the recruitment of eosinophil into the skin, which induces the disease even more. Schulman syndrome, extremely rare. And these rare syndrome, when I say rare, they're quite rare. I mean, most of these syndrome were defined in the 1970s, and from then till now, there's usually between 300 to 500 cases defined. But Schulman, rare disease characterized by symmetrical painful swelling, thickened fascia with eosinophilic infiltration. So this is a fasciitis, and eosinophilic is noted in up to 93% of these patients. Highly responsive corticosteroid. I thought this was an interesting sign for the patient. As the fascia fibrose from this disease, you'll actually see groove sign, which is actually their vein pulling down on their skin. And Ophogy disease, this is actually seen more in the Japanese population. These are intensely pruritic follicular eosinophilic papules, and these lesions can come and go. It mainly affects the face and seborrheic area. And this is just biopsy of a patient presenting with Ophogy disease on their face. Histopathology is sometimes very non-specific. You see the spongiosis, you see the lymphocytic eosinophilic infiltration, but in Ophogy, it's definitely, you can see the eosinophilic infiltration in the follicular area. And then Wells syndrome. Wells syndrome is defined as eosinophilic cellulitis, and in it itself, without any other associated disease, it's definitely infiltration of the skin with eosinophils. They have this kind of very erythrodermic patch that looks like a cellulitis, and then it changes over time to almost a morphea-like presentation. The lesions are very painful. Patient can have associated fever, and it is a recurrent disease. But Wells syndrome is also reported in a lot of cases with other primary hypereosinophilic diseases out there. So primary hypereosinophilia are the ones that leads to the clonal expansion of eosinophils. These are the myeloid and stem cell disorders. And there's a few defined ones out there, but the one that's that is the majority of the hypereosinophilia associated clonal disease is what's defined now as chronic eosinophilic leukemia. And this is due to chromosome 4 abnormality due to fusion genes of the platelet-derived growth factor receptor alpha, growth factor receptor beta, and the fibroblast growth factor receptor fusion genes that can occur, and it causes this oncogenic tyrosine kinase production. So there's also chronic eosinophilic leukemia, NOS. Those eosinophilia, clonal eosinophilia, can also be seen with Philadelphia positive chronic myeloid leukemia, acute leukemia with this inverse transcription of 16. And then it can also be seen in advanced systemic mastocytosis. So in the eosinophilic leukemia, the hypereosinophilia or hypereosinophilic syndrome is a predominant feature. The biggest concern about these, and majority of your patients with a clonal eosinophilia fall into this category, is you have to watch out. They often present with myocardial fibrosis and thrombi formation. So they usually have cardiac symptoms upon presentation. And the important part of the characterization of CEL is that if there is fusion gene associated with the PDFG-RA, so the alpha receptor, because these patients are highly responsive to imatinib, which is actually a very tolerable therapy for majority of these patients. So. And this is just a bone marrow aspirate of a CEL. You could see the intense infiltration of the eosinophil in the bone marrow. You could see there's the abnormal eosinophil with hypodense granules. You could also see increased blast in bone marrow. But it's important to note that early on in the disease, the bone marrow aspirate can be normal. And this is the 2008 World Health Organization classification for clonal eosinophilic disorder, which I won't go through all the gene fusion abnormality out there. And then this is the classification for a CEL not otherwise specified. And then, so what brings you to conclusion, once you rule out all the reactive hypereosinophilia, once you take away all the known classified clonal myeloproliferative disease associated with eosinophilia, then you have eosinophilia otherwise unspecified. And they're the ones with the elevated HE, but no other disease association. Most of the times these patients are asymptomatic, there's no organ damage detected, and majority of the patient with hypereosinophilia, they can tolerate a peripheral eosinophil burden of usually less than 2,000 to 3,000. But these patients, once you rule everything out, they must be followed closely because these patients can present later on with other eosinophilic syndrome. So that's an important factor. Now, if this group of patient of yours, you follow through, and then they started having organ involvement associated with the eosinophilia, then they fall into the category of the hypereosinophilic syndrome. And you have to, in these patients, actually treat based on their involved tissue diseases and also their eosinophilic burden. Go through the process of going through the differential diagnosis again. Think about therapy with glucocorticoid steroid therapy, interferon alpha therapy, and possible anti-L5 therapy. So the approach to hypereosinophilic syndrome, you definitely have to assess their severity early on. If you have a patient with hypereosinophilia and they already show cardiomyopathy, potential cardiac involvement, lung involvement, then you have to consider treatment for that pathway first with immunosuppressive and get them through the right consultation. But if their presentation is not that severe, then you go through the differential diagnosis. Definitely get a very thorough medical history. Definitely remember cancer screening history, HIV risk factor history, travel history, and extensive medication history. And the workup, of course, in our part, we definitely do our allergy and asthma workup. But other consideration is CBC, differential, of course, chemistry, of course, urinalysis, and troponins, even in children. So if you have children with significant hypereosinophilia, get a troponin. They may have cardiac involvement already. And then for the oncogenic presentation, definitely consider vitamin B12, which is seen in eosinophilic leukemia and lymphoma. Elevated tryptase can be seen in the leukemias and lymphomas also, but can also be seen in our indolent systemic mastocytosis. SPEP for elevation in the IgGs and IgMs. Ova and parasite, definitely, if they have a travel history or subtrophic trophic history. And then definitely consider the autoimmune workup with ANA, ANCA, ESR. And finally, don't forget HIV screening. And then with the workup, there's definitely the imaging studies that you have to consider based on their presentation. And one of the recommendations in the World Health Organization is to actually do the FIP1-like1 PDGFRA mutation analysis, and the Mayo Clinic does this analysis. So if you have a HES patient with this, this is with a presentation highly concerning for an oncogenic potential. Send this in because these patients, like previously discussed, are highly responsive to imitinab, and the earlier the treatment, the less organ damage they'll have. And then heme consultation, we send it to them to do the bone marrow biopsy and most of the phenotyping. One of the important things is when you send patients in for bone marrow biopsy, make sure they not only do an aspirate smear, but do a core biopsy so they could do a lot of histology and immunochemistry that's necessary to classify the clonal eosinophilia. And that is it. How did I do for time? 15 minutes.
Do you think we should be doing more screening CBCs?
I think so. Yeah, I think so. So, I don't know, over the past year, when I was starting to do this talk, and I was curious, and I was like, over the past year, for my urticaria and angioedema patients, how many of them have elevated eosinophils that are concerning? And within the past year, we see so many urticaria and angioedema patients, and this is not just your, incidental finding, but I would say I had 3 with hypereosinophilia. Yeah, and of course, like 1 or 2 of them are just right on the border. No other symptom except these intermittent urticaria with eosinophilic count of 1,200, 1,400, 1,600,